Okay, well, thank you everybody for joining us today. We've got Jared Moore, who's one of our faculty members at the Morehouse Plaza presenting today. He's going to be discussing aspirin as a means for primary prevention of cardiac disease. So without further ado, I'm going to turn the microphone over to Jared. Thank you, Jared.
All right, so I signed up for this topic back in early September because I thought it was an area that was a little bit confusing to me. The United States Preventive Services Task Force decided to come out with a draft recommendation for new recommendations, which added potentially to some of that complexity. So we're going to try and work through that to give a clearer sense for when we might think about using aspirin and what are some new thoughts in the way that it could be used for primary prevention, not just for cardiovascular disease, but also for colorectal cancer and other cancer prevention.
Okay. There we go.
So initially, aspirin was thought for primary prevention for cardiovascular disease, strokes, recognizing that side effects associated with that include bleeding, most significantly gastrointestinal bleeding, but also intracranial hemorrhage. Now, with new data emerging, questions about potential benefits of using primary prevention with aspirin for prevention of colorectal cancer as well. Reasons for this are that cardiovascular disease leads to about 30% of deaths annually in the U.S., and colorectal cancer is the third most common cancer and leads to 50,000 deaths annually. Therefore, in September 2015, the USPSTF developed a draft statement combining recommendations for primary prevention for aspirin for cardiovascular disease and cancer. In the statement, they state that each person really just has one decision to make, whether or not to take aspirin for prevention. That could be prevention for cancer, prevention for strokes, prevention for heart attacks. So to think about each one independently is not really a real-life application for that. Really, we should be thinking about the sum of all the potential benefits and risks associated with it. Steve Nissen up at Cleveland Clinic states, I strongly disagree with this. In fact, so does the FDA, and we'll talk a little bit about what he means by that as well. So although this is a draft statement coming out, certainly a lot of controversy associated with it. We're going to review some of the pharmacology of aspirin and why it's thought to be beneficial in cardiovascular disease and cancer prevention, review the draft recommendations, and then answer a couple questions regarding aspirin, such as high versus low dose, enteric versus regular, amongst others. Here are a couple cases that we'll consider. A 61-year-old white male has hyperlipidemia, recently started on a statin, impaired fasting glucose, which increases cardiovascular risk. Father was a smoker and had an MI at 53, and his 10-year ASCVD risk was 11.6%, and that's prior to being on a statin. 61-year-old white male, fairly similar. However, no family history of cardiovascular disease. Blood sugars have looked great, and 10-year risk is 12.7%. So let's first talk a little bit about aspirin. This is maybe a little bit of a review, but aspirin is a permanently inhibits cyclooxygenase. At lower doses, it inhibits COX-1, which decreases platelet thromboxane and platelet aggregation and adhesion, which is what primarily drives some of the cardiovascular benefits. However, there's also thoughts that platelet aggregation surrounding cancer cells also provides protection for cancer cells. And so aspirin in itself, by decreasing some of that platelet aggregation, can actually allow the immune system to more effectively identify and destroy cancer cells. And that's thought to be one of the processes in which it can help prevent cancer. However, in COX-2 inhibition, that generally only occurs at higher doses of aspirin, and that inhibits tissue prostaglandin. So it has anti-inflammatory effects, and along with that, also anti-cancer effects. However, it can also cause endovascular injury associated with that, and that's some of the thought process behind NSAIDs and higher doses of aspirin potentially contributing to some cardiovascular disease process and why some of that risk benefit gets. There's also some COX-independent pathways that can decrease cancer effects. So we'll talk a little bit more about what this means later on. So in 2007, the USPSTF made the recommendation for aspirin and NSAIDs for the prevention of colorectal cancer and gave it a grade D ranking, basically saying do not use this. In 2009, they came up with new recommendations for cardiovascular disease prevention, and they separated these out by men and women, and also separated it by prevention of MIs and strokes, and specifically non-fatal MIs and strokes. And this applied to men ages 45 to 79, and the benefits seen in men were for reduction in non-fatal MIs. And for women, the reduction for ages 55 to 79 for non-fatal ischemic strokes. And of course, these benefits had to outweigh the potential harms associated with bleeding. And they gave us this nice table to be able to use, and it differentiated risks based on Framingham risk scores. And you could use this to try and determine whether or not to put your patient on aspirin for primary prevention for very different reasons. This was great, except for the women's studies were very heavily weighted towards the Women's Health Initiative, which was a slightly younger population and therefore thought to maybe have skewed some of the data with regards to stroke prevention and MI prevention with the use of aspirin. And so over the past couple of years, as more studies have come out, some of those gender-specific recommendations are probably going to go away. Interestingly, in 2014, however, Bayer applied to the FDA for another indication for aspirin for primary prevention for cardiovascular disease. And the FDA refused this based on a lack of evidence showing potential benefit. So it's a little bit interesting that the USPSTF is now coming out 1 year later with their new recommendations, just a year after the FDA. But again, it is a combination of cardiovascular disease prevention as well as colorectal cancer prevention. So a little bit of a different model that they're using for this. Since the last set of recommendations, there have been 4 new cardiovascular disease studies evaluating this and 8 new colorectal cancer studies. Some of the colorectal cancer studies are sort of buried within the cardiovascular primary prevention studies, and that's the way that they've gotten some of their data. And so in this new one, they've used a composite risk-benefit assessment using cardiovascular disease as well as colorectal cancer prevention, and have also used the newer HA and ACC 10-year ASCVD risk calculator, which I think most of us are using now, so it makes it a little bit more applicable in our everyday practice. We don't have to go out and make sort of 2 different calculations to try and determine this, which is kind of nice if this is what finally gets approved. They've lowered the grade of the recommendations and also changed the age range for which they apply. They also no longer differentiate between men and women. And so the age recommendations, again, this is a draft. The age recommendations are 50 to 59 for both men and women. They get a grade B. And this is for anyone with a 10-year risk greater than 10%. No increased risk for bleeding, and then a life expectancy of at least 10 years. And we'll talk about why this is later. That's because, a little bit more later, but primarily it's due to the fact that it takes about 10 years to get the benefits, the colorectal cancer prevention benefits from aspirin. It takes about 10 years. And then, so they have to really pretty much be willing to take it for 10 years consistently. Age 60 to 69 is a grade C recommendation. Same criteria, just a lower grade recommendation. I tried to take some of the data from all the different studies that they use and put it in one table. And I'll send out this table to everyone as well. It's here on the table. Anybody hasn't had it, but I'll send this out in an email. And try to put this sort of visually to see where we see benefits and harms and how doses of the aspirin can affect it. So from an all-cause mortality, in the green, we see a significant benefit when all doses of aspirin are considered. When only low-dose aspirin is considered, there's a non-significant benefit. It's pretty similar. There's just a slightly wider confidence interval. They thought that in general those values were probably about the same. There's just less data for aspirin less than 100 milligrams, so it didn't reach the significance level that it did for all doses, but functionally it's probably the same number. There was no benefit seen for cardiovascular disease mortality, however, so the large portion of the mortality improvement is seen with cancer prevention. Non-fatal MIs were significantly reduced with both all doses of aspirin as well as the low-dose aspirin. But interestingly, non-fatal strokes were only reduced for aspirin less than 100 milligrams. And this is thought to be related to some of that difference between the COX-1 and the COX-2 inhibition, where you may actually promote some endovascular injury as you're getting more COX-2 inhibition and prostaglandin synthesis disruption. So again, the thought being that the lower dose aspirin may actually be more beneficial in preventing strokes. For colorectal cancer mortality and incidence, there wasn't enough data separating dosings, and so they couldn't make a differentiation between low dose and the higher dose aspirin. However, they felt that they saw significant effect, or they saw effects even at the lower dose, so they felt fairly confident that using a lower dose aspirin would probably be efficacious in limiting colorectal cancer mortality and incidence. But significant decreases in both of those areas, but only after about 10 years of use. So it really requires a long-term use of that. Bleeding risk increases as well at both doses for GI bleeds, but a little bit less for the hemorrhagic stroke in the lower dose. So basically the sum of this is that lower dose aspirin should be equally effective to higher dose aspirin. Here's a table that looks at lifetime events per 1,000 people. And this is separated in this slide by women and by age ranges. You can see per 1,000 people looking at MIs prevented, ischemic strokes prevented. This is at a cardiovascular disease risk of 10%, ASCVD 10-year risk score of 10%. And tracking across here, we see net life years gained at 21.9 and quality adjusted life years gained at 62.1. And that's likely due to reduced numbers of MIs, reduced numbers of strokes, and the potential sequelae associated with those, even if it does not cause mortality. At age 60 to 69, we see that net life years gained is actually negative. However, we still see an improved quality adjusted life years gained. So this is why some of the data in that 60 to 69 is in 60 to 69 age range is at a grade C and really more individual to the patient. We see the same pattern for men, and I won't go through that in detail, but again, this net life years gained is negative at 60 to 69 for the 10% risk range. So some of the opposing view is that there's significant heterogeneity in the studies. Obviously, the FDA did not think that the cardiovascular disease data was significant just 1 year ago. And so that there are dangers of combining two sets of controversial data into a single model and saying, hey, maybe now it's significant when it maybe wasn't as significant before or not as. So that's something. There's also concerns associated with the ASCVD risk calculator, and we've heard about this before in terms of potential overestimation of cardiovascular disease risk. So again, using that calculator on top of other data has raised some of the concerns. There's also concerns that there's significant decrease in incidence and improved mortalities with other interventions. So, for instance, high-dose statin or moderate-dose statin. If we got everybody on appropriate statin therapy, we may improve outcomes even more than by using the aspirin. And now we're just increasing some risk associated with using aspirin. So maybe using other modalities, improving blood pressure control. We just had the SPRINT trial come out telling us we should lower blood pressures. Improving compliance with lipid-lowering therapy, maybe those things would be more beneficial than adding in aspirin as primary prevention with lower risk associated with them. High versus low dose aspirin, haven't really seen, at least from the data, that there's a significant difference between the two. So there's really no data. Sometimes I see 162 milligrams or the 365, but there's really no data supporting that. Really, the low dose, less than 100, so 81 milligrams should be fine. There may be a dose response curve for colorectal cancer, but that hasn't been completely elucidated yet. Every other day dosing, sometimes people ask about that. For colorectal cancer prevention, they found that that was probably equivalent to daily dosing, but there's no data for that for the cardiovascular disease prevention. And enteric-coated, no difference observed in cardiovascular disease risk reduction, but also not necessarily significant improvement in GI symptoms or anything else, so probably not necessary. So the low-dose aspirin can certainly be effective in preventing heart attacks, strokes, and colorectal cancer. It just depends on risks and benefits associated with that. It seems like we're going to no longer need to differentiate men versus women in terms of risk profiles. We didn't talk about this at length, but diabetes should not be used to independently determine the need for aspirin. Diabetes is included in the 10-year ASCVD risk score, and that's how you should use it. You should not use it independently to say that someone should be on aspirin. And then, again, the other risk-modifying treatments, lifestyle modifications, may ultimately be more efficacious than aspirin, and therefore we should really focus on improving those areas as much as possible. So going back to our cases, 61-year-old white male with significant risk factors, including a family history in impaired fasting glucose, versus the 61-year-old white male who has hyperlipidemia, but a relatively similar ASCVD risk score, and whether or not to start aspirin on these two people. In this case, I think, I would certainly have the discussion. If we look back at our tables, it tells us that there is a potential negative net life years gain, but potentially significant improvement in quality-adjusted life years. For the first patient, I think you can make a strong argument for potentially starting aspirin, given the strong family history, plus the glucose intolerance and elevated A1C, which is not included in the 10-year ASCVD risk score, but does significantly increase risk for cardiovascular disease. So if this person has very limited risk for GI bleeds, then I think you can make a strong argument for that. And for the second patient, I think that one's even more difficult. I would be a little bit probably less inclined to push as hard for aspirin in this person. I think it'd be a little bit of a longer discussion and think about trying to use other lifestyle modification, making sure he's on the correct statin and continuing to have that discussion with him. But I'm not sure that it would be as easy in him to necessarily convince myself to start it. So there are the references. Tried to keep it to about 10 or 15 minutes. I know that's a lot of information, but I'm happy to take questions.
Great. Great, thank you so much. I'm going to kick things off with a quick question, then we'll open it up to everybody else. So reduction of cancer risk, I have to admit, that's not a real common part of my conversations with my patients when I discuss the merits of being on aspirin. So you base part of the discussion on the risk of cardiovascular disease. You base part of the discussion on the risk of colorectal cancer.
So that's I'm definitely thinking about doing that now, and I think that that's going to have to be part of the discussion. I like the quote at the beginning where it says there's really only one decision to make, whether or not to take aspirin, and you have to really consider all the potential benefits and risks associated with that. And if some of the benefits now are in cancer prevention, then I think it needs to be part of the discussion. So I have had that conversation with a few people so far. It does definitely complicate it and make it more difficult, and it ends up being a longer discussion than it maybe was even initially. But I think that that's important, especially because the model that they use really, number one, the cardiovascular disease prevention occurs within about 5 years. So the benefits used in this model require that people be on it for 10 years. So you really have to take into account a little bit more life expectancy and quality of life, and that colorectal cancer prevention has to be a discussion as a part of that. So,
well, I can see that changing the way I practice in the sense that if I have a conversation with a patient and I'm doing their preventative health assessment and I see that they do have a strong family history of colon cancer, it's interesting to kind of fold that into the overall conversation about being on aspirin. We sort of, I think, traditionally have just limited it to a cardiovascular conversation.
So some of the gastroenterologists are, I don't know if anybody else has seen this, but are recommending aspirin now for primary prevention, especially if they have hereditary cancer syndrome of some sort, Lynch or FAP or something like that. But even if they have stronger family histories, you'll sometimes see them recommending that a little bit more frequently.
Okay. Well, we're going to open up broader questions. So the one request I make is anybody asking the questions, we'll just take them one at a time, so that everything records really clearly for folks that want to watch after. So Guiban has a question here.
So here the age group 50 to 59 and 60 to 69. Do you have any data about the older people? Because on the BS criteria, I always talk about when patient age over 80, it's not a good idea to start aspirin for primary prevention. So there's a gap between 70 to 79. Do you have some data about it?
It was insufficient data to make any recommendations on the newer sets of recommendations from the USPSTF. The older ones included 70 to 79. The newer ones do not. So I think that that's going to have to take into account life expectancy and all of the other things that we just discussed. But it's not going to be part of at least this recommendation. So that will be sort of a gray, even more of a gray area.
Okay. Other questions? Dr. Aldiev has a question.
So traditionally, we think like the risk of bleeding is the only harm that can come with aspirin, correct? This is how I used to practice. There's a lot of patients already taking aspirin prior to coming to see me from over-the-counter. We think it's good for our heart, but there is no clear indication. Should I tell them to stop now? No, but this is negative life expectancy making me feel it's, wow, we're making harm if we don't stop it now.
Yeah, so I mean, I think aspirin has been sort of part of the culture. People say, oh, I don't know, I'm 50 or so, maybe I should take aspirin. And I think you see a lot of people coming into your practice that do that. You know, their parents took aspirin, their friends tell them to take aspirin. And so I do tell people to stop if I don't have a clear indication for them to take it, and I discuss with them those risks. It always feels a little bit hard to stop something because you feel like maybe you're, but if there's not a clear indication, you have the discussion with them and say, hey, you know, here's where it is. If you want to continue taking it, okay, but this is what the risk and benefits are. I wouldn't recommend, if you were coming in right now, we wouldn't recommend it for you. Yeah. Is how I approach that.
Yeah, exactly. But I used to say, okay, the only risk is bleeding. If you're doing well, tolerating this fine, it's up to you if you want to keep taking it. But probably now I have to change the conversation.
So the bleeding risks, these are pretty significant bleeding risks that they account for in this. It's hospitalization or need for transfusion. So it's not sort of whatever you would count as a minor bleed. Yeah. Intracranial hemorrhages are obviously bad no matter what. Now, the incidence of those are very small, so even though the relative risk is fairly high, is increased fairly significantly for that, the overall incidence is very low, so it's a very small number of people actually have that complication. The GI bleed has a relatively low incidence as well, but the bleeds that people have are significant with that. But, you know, maybe that's not so bad. You know, for some people who have higher risk, getting the transfusions maybe not as bad as having an MI and having a cardiomyopathy and heart failure and everything else afterwards.
Thank you.
Mm-hmm. Other questions? For the folks on the phone, you can unmute your phone if you have any questions to ask Jared.
Jared, I have a question. It's Andrew Seamus on the phone. Can you hear me?
Yes.
Just wondering, it looked to me like the most impressive benefit was in colorectal cancer prevention, and it sounded from what you said like that data was mostly sort of a secondary outcome in cardiovascular studies. Do you know if there's any work underway looking at that as a primary outcome, and perhaps, you know, even thinking about starting aspirin for people in their 40s, seeing as the higher incidence of the cancer is in the 50s? You know, you start 10 years before the,
There are a few studies ongoing right now looking at aspirin for colorectal cancer prevention. Some of the challenges with them are in how they, with improved surveillance and techniques with colonoscopies, the rates of finding polyps has increased as well. And so how that is used to calculate into some of the colorectal cancer prevention is pretty tricky. So as you look through the past studies that have been completed, trying to determine people who have had polyps in the past, what types of polyps they've had in the past, and what their outcomes are, and differentiating along those lines has been one of the challenges in evaluating the data. There are a few ongoing right now, but I think that it's going to take a little while for that data to come out just because there's such a delay in effect associated with it. So, did I answer your question?
Oh, yeah, yes, yes, you did. Yeah, thank you.
Okay. Any last questions before we break? All right. Well, I want to thank Jared for joining us today. You know, the topics that we've had come to this mini grand round series, I think, have all been really high impact, and this is something where I'd probably say is a very high impact just because so many patients are on aspirin, and there's such a strong sort of historical legacy of using aspirin. The data obviously keep changing and recommendations keep changing on us, and really maybe the best thing we can do is just try to keep up to date as much as possible so we can share that information with our patients. So thank you again. If you guys have any other questions, I'm sure Jared would be happy to answer them via email if you want to fire something off in the future. But we'll consider him our resident expert on aspirin for primary prevention.
And I'll send out some of these tables just for easy reference.
Very good. We'll send the survey out here shortly. And if you didn't attend, if one of your colleagues want to watch, we'll send the video out about 5 to 7 days from now. Thank you.